Hi everyone, welcome to our Unit 7 discussion. So today we're going to be talking about some more advanced equipment, anesthesia, and even we're going to touch a little bit on some emergency things that might happen in the OR. So our objectives are going to be to discuss some of those specialty equipments like microscopes. We've already talked about robots, um, different monitoring devices, basic functions of anesthesia and airway management, and then this emergency situation that might come up in your OR called malignant hyperthermia. Now, notice the spelling here, and it's a common mistake. Make sure it is hyperthermia is what we're going to be talking about, not hypo. So we'll get into that here in a bit. Here are your assignments for Unit 7. You do have a couple big point things here worth 100 points. Make sure you're getting those in because this is your last full week of this quarter. Next week, you only have until Tuesday to get your assignments in, and then the quarter is over. So make sure you're getting anything that you haven't done. Go back and make sure that you get those turned in. Don't take zeros for those. You can still turn those in, okay? I'd rather see you get them done and get a decent grade than take the zero. So still get the discussion posts in for this week. It should have been by yesterday, but also go back and respond to one of your peers, and then also wanted just to draw your attention to what next week's assignment will be. It's a discussion post. It's more of like a reflection post that you're going to go back and basically summarize everything you've learned this quarter. You still need to cite your sources, okay? But you do not have to go back and respond to your peers unless you want to, which is perfectly fine. And that is due Tuesday by roughly noon in Central Standard Time. Okay. So let's talk a little bit about microscopes first. Microscopes can be a little intimidating, especially for new students coming in. You're going to see microscopes in these particular types of cases most often. So neurosurgery, we're working in the brain. We're doing some very detailed, fine stuff. So surgeons will often, like in this picture here, be right up on that microscope along with their assistant to see what they're getting into with the brain and even spinal cord. So neurosurgery, you see microscopes very often, all right? Ear cases, now, depending on the type of ear case, sometimes the surgeon will can get by with an otoscope. It depends on what they're doing, but often if we're doing anything from putting in tubes in the ears, like a myringotomy or tympanoplasty, or going to even deeper and maybe doing like cochlear implants, that sort of thing, they're going to need a microscope to see down in there. Microvascular surgery or any microsurgery, it doesn't necessarily have to be vascular. If you're reanastomosing, let's say, fallopian tubes or even the vas deferens because they want to change their mind on having kids and they want to reanastomose those vessels, ducts, they're going to need a scope because those are small tubes there. Ophthalmic, so anything on the eyes, like within the eyeball or behind the eyeball, they're going to be using a microscope, like cataract surgery, fixing detached retina, anything like that, they're going to have a microscope. So there are a lot of varieties of microscopes. Often it looks very similar to this really top and bottom picture, but you're going to have optics on one side for the surgeon and usually at least one more on the other side for an assistant. So they can properly suction, dab, whatever they need to do. On the other side, and often you can still hook it up to an extra monitor so everybody else in the room who's not directly under those eyepieces can see what's happening. That's important for everybody to know what's going on because it's really hard to see sometimes down in maybe a small incision. So here's another type of microscope here, but some special considerations you need to keep in mind as a surg tech when we're working with microscopes. For one, you have to be very careful with them. And when I say they're expensive, that's an understatement, okay? They cost a lot of money, right? Even like just accidentally bumping one of these eyepieces could crack or break it, right? Or making sure you're wiping it down properly and you're not using anything abrasive on the lenses. Those things can really mess up the whole system. So be very careful. They're all on wheels, so they can be moved from room to room if necessary. But when you're moving them down the hallway, be careful that you don't run into the wall with them or whatever. It can be tricky sometimes. When the microscope is in use, like that picture I showed you on the previous slide, the surgeon's looking under that microscope, right? As a surg tech or even anybody in the room, be very cautious about how close you get to it, that you don't bump it. Because when you bump that microscope and the surgeon's looking under it, it's amplified, it's magnified by, anywhere from 10 whatever times what you would normally see. So any small movement is going to look like an earthquake under that microscope. And it can be really damaging to what the surgeon's trying to do. It could cause a problem, it could mess them up. So be very, very careful. It will make them mad if you bump their microscope. All right. And then we'll talk about draping here in a few, but you got to be very careful when you drape a microscope. If this is a type of procedure that is sterile, some ear cases, depending on what it is, if we're just putting in ear tubes, my surgeons don't drape this microscope because it's not necessarily a true sterile case, even though you should still follow a good sterile technique. But they don't put a microscope drape on for like ear tubes. But neuro, eyes, those types of things, you absolutely will drape this microscope because you're bringing a non-sterile item across a sterile field. So there are special drapes that fit each type of microscope that have to be applied correctly. You also want to check the lenses. And it may be more old school microscopes, some microscopes have lenses that you can take off and change the magnification or the optics on. So like our surgeon who was doing like a direct laryngoscopy wanted a 400 lens. So we would change it out for the 400 lens. Kind of going back to not bumping the microscope, you will need to pass these instruments very carefully to the surgeon, because if they're looking under the microscope, they're very focused. It would be hard for them to look up and down, like up away from the field of vision back through the microscope. It would be really hard for them to focus over and over again to look up for instruments to go in their hand. So often what you'll see surgeons under a microscope do is they'll just keep looking and they're just going to hold their hand out in a way that's correct for that instrument and expect you as the surg tech to place that instrument in that hand appropriately in a way that they can use it so they don't have to readjust it or look at it. So you need to be very confident with how you're passing your instruments to these surgeons in a careful manner, in a way that they can just use it right away without readjustment. So that does take some practice as a student, being confident with your instrument passing. So to drape the microscope, and I tried and tried to get this video to load about how to drape this microscope, but my computer or PowerPoint just was not having it. It would not sync. So if you wanted to pause it and go to this, type it in, you're welcome to. It's not a long video, it's like 2 minutes, but it shows you how to drape a typical Zeiss microscope. It's a common brand, ZEISS. So, and even if you have a different brand at your facility, it's going to be the same concept. So when we're draping microscopes, it's important to remember, and anytime you're draping anything, to protect your sterile gloved hands, because it's easy for them to like slip out from under the protection of the drape, and you might accidentally contaminate your gloves. So you don't want to have to change gloves, and you don't want to accidentally contaminate and maybe not even realize it. So always, always protect your gloved hands when you're draping anything, right? Another thing to keep in mind is as you're draping it, you're going to keep a little bit of slack around the arm piece of the microscope, because sometimes they'll raise the microscope up away from the field if they're doing different dissection, or lower it so they can use it and see. So there might be some adjustment needed, that you don't want the drape too tight. So let's move on to the airway pertaining to anesthesia. So obviously as a surg tech, we're not intubating patients, right? That's not within our scope of practice. But we still need to be a vital member of the team and know basically what everybody's doing. And, anesthesia might actually require a second set of hands sometimes. So you need to be aware of what they're doing. In anesthesia, airway selection does affect your cases sometimes. So, for example, if you are, and I put this kind of down here, but if you're going to be doing a surgery on the back and the patient needs to be prone, just laying on their stomach face down, but the case requires them to be under general anesthesia with this ET tube placed down their throat so they can breathe, you can't be laying directly on that prone, face down on the table. So there are certain things that you're going to have to be mindful of when you're positioning that patient who has a tube, not pulling it out or, being careful with it. But you're also going to have different positioning devices that would kind of elevate that away from the face. And so they're not laying directly on their face. So you'll see that a lot, like in back spinal surgeries, maybe the Jackson table. Anesthesia actually has a separate, it's like a face shield almost that goes directly on their face to keep pressure off of it, but still allows the tube to come out and they can still monitor that airway, keep an open airway. So something also that is very important for the surg tech or anybody in the room, to be honest, is anytime anesthesia is intubating the patient, putting in this ET tube. ET tube stands for endotracheal. So this long tube, they're going to go through the mouth, they're going to visualize the vocal cords, okay? And then they're going to slide it past the vocal cords into the trachea. So endo inside the trachea, endotracheal, okay? Whenever they're doing that, they're they've been given usually a muscle relaxant, sedatives. They've been given drugs here. So at this point, while they're putting that tube in, the patient's senses, all five senses are starting to disappear. The sense of, they're not going to be able to see anything, feel. We want to make sure that anesthesia is pain-free, right? No movement, so that's your muscle relaxant. One of the side effects of that is, though, as they're going through those phases of anesthesia, actually stages of anesthesia, they are more at risk for developing something called a laryngospasm. So as they're being put to sleep, okay, the patient's hearing is the last sense to go. So their vision is going to go pretty quick, movement, that's pretty quick. Their hearing is the last one to go. And if they can hear really loud sounds, like you're banging instruments around on your back table, it can actually cause an automatic response in their body that triggers a laryngospasm. So when a laryngospasm happens, the vocal cords like slam shut. Okay, so if they don't have this tube airway secure and the voice box is slammed shut, no air is going to get through. Okay, no air from the trachea is going to come up through the larynx. Then they can't breathe. Okay, so it can become an emergent situation because a laryngospasm was triggered. Now, there are some drugs and things they can do to try to break that laryngospasm, but it still will compromise their airway, and you don't want that to happen. Now, the same thing can happen also while the patient is being extubated. At the end of the case, when they're trying to take this tube out, they're going to try to make sure that the anesthesia drugs have worn off, that they can respond to certain stimuli, and that they can breathe on their own before they take this tube out. Okay, if they are starting to take this tube out and you again are like cleaning up the room really loudly, or the music is still playing loudly from the case, it can again still trigger a laryngospasm. And at this point, it's going to be hard to get that tube back in. So be very mindful of what anesthesia is doing, because if you're not, you can cause harm to the patient, but anesthesia will yell at you. I've seen it happen to lots of students. They're not paying attention to what's going on, and anesthesia usually is not very patient, and they'll yell loudly. at anybody in the room that is being loud, because they don't want to have to deal with that patient. So just be very careful. Also to remember, if you are unsterile, if you are not scrubbed in, setting up your table, sometimes you're an extra person in the room, okay? You need to be up by anesthesia because they can often use the second set of hands. You see this little thing coming out the end of this ET tube, that's called a stylet. Now, once anesthesia gets this tube in place, they often, it's kind of a struggle sometimes. And watching anesthesia is like an art. It's really cool to watch them do what they do. They may need you to pull this stylet out. You can do that under their supervision. Just carefully and slowly pull that stylet out, because this tube is then going to be hooked up to the tube that goes to the machine with oxygen. So that's something you could do. They may even have you press down right above the cricoid cartilage on the neck to just gently press down so no stomach contents aspirate into the lungs. So always be available for anesthesia, because things happen and they could use extra hands sometimes. It's not that you're ever administering any anesthesia at all. That's not what that is. So also different surgeries require different types of anesthesia. So your different types could be a general anesthesia where they're completely unconscious, not moving, should have no recollection of the surgery, pain-free. Those are our goals for anesthesia. If that's the case, they will put in that ET tube or possibly what's called an LMA. So that stands for laryngeal masked airway. So it's a different type of tube in that it doesn't go past the vocal cords and into the trachea. It sits on top of the vocal cords. So they don't have to have muscle relaxant for an LMA. They would for an ET tube. So it's different types of cases may require different things. If it's a short case, trying to think of a good example. A shorter case, but they still need to give them enough meds to like keep them pain-free or sedate them enough, they'll put in an LMA. Now, your long neuro cases, anything abdominal, orthopedic, like a total hip replacement, something like that, you're going to have an ET tube. That's a big case. Now, MAC stands for monitored anesthesia care. This is like what some patients refer to as twilight, like they were half out of it, kind of sedated, don't really remember what happened, but they were not truly put to sleep like we would call it. They didn't have to have any type of airway management. Now, they would still monitor their airway for sure. They're still going to have their EKG leads on. They're still going to have pulse ox. They're going to monitor their temperature. All of those things will still be monitored. They just don't have a tube in their trachea. Okay, so another type of surgery is local anesthesia. So if we just need to take off, let's say a mole on the hand, it looks suspicious, maybe it's cancerous, just a small mole. That patient, if they are capable of laying on the table and they're not at risk for anything else, we could do it under local. So they would just inject a numbing medicine, a numbing anesthesia like lidocaine or sensorcaine, bupivacaine, whatever the surgeon chooses, to take that off with no airway tube needed whatsoever. Sometimes in local cases, depending on what it is, anesthesia may not even be in the room. Okay, I've seen that happen. The patient would still be monitored by the circulator, should still ideally be hooked up to EKG just in case something happens, in pulse ox. But those are the three main types of anesthesia. And when we're talking about airway management, we're most often referring to general surgery. Okay, and like I said before, be mindful of tube placement during positioning. You never ever want to compromise the patient's airway or tube. All right, let's move on to malignant hyperthermia. This is one of those complications in surgery that is actually quite rare, but it happens enough that we need to be able to recognize it very quickly. if it does happen, because if you don't recognize it soon enough, the patient will die. This is a very serious complication related to general anesthetics. So it's actually because of a genetic, basically a predisposition or a genetic mutation that causes your body to react to certain types of anesthetic drugs. Okay. And when that happens, your muscle essentially will contract. It's a sustained contraction and causes that muscle to break down and release a bunch of calcium into the bloodstream, which causes a lot of issues. So here are some of the signs. The things that trigger malignant hyperthermia are succinylcholine, which is this word right here, sucks, or volatile anesthetic gases. Those are the two types of triggers for malignant hyperthermia. And I promise you some sort of question like this will be on your certification exam. So you need to memorize that and basically all of this info about malignant hyperthermia. They love to ask those questions. So those are the two triggers. And when I say volatile anesthetic gases, I'm talking about usually the gases or vapors that end in ane, A-N-E. So sevoflurane, desflurane, isoflurane. Those are your triggers for MH. Now, things that won't trigger it would be like nitrous oxide. That doesn't trigger it. Okay, even though it's something they're breathing in, it's not a trigger. So your AINE drugs, your volatile anesthetics, and succinylcholine, right? Those are the triggers. So if they suspect that MH is occurring, the first thing they're going to do, anesthesia-wise, is discontinue those. They're going to also give 100% oxygen. And the next thing they're going to do is get a drug called dantrolene. Now, this is not just something anesthesia has to deal with. This is an all hands on deck situation. So once it's detected or anesthesia is like, yes, I think this is what's happening, everybody only has minutes to react. Because if you do not treat MH within, I think it's approximately 15 minutes, the morbidity rate goes up to like 85, 90, close to 100%. It's guaranteed that they're going to die if it's not treated. So it is very serious. Every team member should have a role in how to treat MH. And a lot of facilities have a cart set up with everything you need to treat an MH crisis. So what ends up happening, and usually it's divided by early and late signs. This is how you recognize it. The very first one you're typically going to see with MH is an increased, where it says ETCO, that stands for end tidal, TIDAL, end tidal CO2, carbon dioxide. Because as your muscle is breaking down that calcium because of that hypercontracted state, part of that chemical reaction that's happening is an increase in carbon dioxide being released into the blood. Carbon dioxide release is a byproduct of cellular metabolism, so that's why it happens. So that gets built up in the blood, carbon dioxide. Typically, when we're breathing normally, we're breathing in oxygen and exhaling carbon dioxide at a normal pace, right? So if we have all this extra carbon dioxide build up in the blood, your body is going to try to get rid of it. It's an automatic response. So that's why you're going to start to see tachypnea, which is increased breathing or expiration of that carbon dioxide, and tachycardia. Your heart rate will also increase to try to get rid of that extra carbon dioxide. Also, the more carbon dioxide you have in the blood, the more acidic it becomes. So you'll see signs of metabolic acidosis in the blood. You're also going to see masseter spasm. So that's your muscle that like helps you chew right here on your jaw, the masseter muscle. So even though they might be, anesthetized, they can't tell you what's happening. That could be something you could see, right? Now, later signs, and sometimes this number 1 here, hyperthermia, is kind of a mid to late sign. So hyperthermia is an increase in temperature. The concern here is that the body temperature can get anywhere from, your normal temperature is 98.6 degrees Fahrenheit, right? This can shoot up to 105, 106, 107 degrees Celsius quickly within 10, 15 minutes if it is not treated, which at that point, you're basically melting from the inside, 170 degrees, 107. Trunk rigidity, because remember, muscle spasms, right? And eventually, if you had a Foley catheter in, you could see myoglobinuria. So you're going to have myoglobin, which is from the muscle, in your urine, urea, okay? So pay close attention to these early signs if they start to see increased end-tidal CO2, because that's the thing they monitor for in anesthesia. The tube that they put in, that ET tube, has an extra tube that goes to a carbon dioxide monitor for that reason, right? So they'll see an uptick in that, and they might mention it to you. This has been on a couple med shows. If you ever watch like Grey's Anatomy or The Good Doctor, I think it was The Good Doctor. It was a couple seasons. It might have been season 1, I think. And they said it. They said anesthesia was like their CO2 level was rising, and then their heart rate started to rise, and they're trying to figure it out like it was a big mystery. And I'm sitting here yelling at the screen like, "Hey, it's malignant hyperthermia," and that's what it turned out to be. So it's kind of ruined med shows. But anyway, obviously the surgeon will be informed. Now there is a number, and it should be on this emergency card, this MH card, that there's actually a malignant hyperthermia hotline. Because it doesn't happen often enough, sometimes people get out of practice of like, oh, what should I do next? You can call this hotline and they'll walk you through it. So if you are on call and you just don't know, call the hotline. They will help you. Some things that might look similar to this could be one of these items. But once you start tacking on like a couple of these, it's going to become pretty obvious. Now, another thing, and it's not listed here, that you might end up having to do, especially as a surge tech, is get a slush machine. So we have like a machine that can turn saline into basically ice or slushy, like a slushy, right? What we need to do in order to prevent hyperthermia of their body getting too hot, we're going to pack as much cold things, ice, slush, in any open body cavity that we can, any body orifice. We will put cold saline or ice, okay? Pack it near the neck, the head, the axilla, the groin. If the body is open, you've made your incision, you'll put sterile slush inside the body. You have to get their temperature down, okay? The other thing they need to start doing, like I said, this drug here, dantrolene, could be something you end up having to do. So you need to memorize this dose because it's a common question. To administer dantrolene, it's 2.5 milligrams per kilogram, okay? And this is a drug that unfortunately is, it needs to be reconstituted. So it comes in 2 vials. You have to mix the powder with the sterile water. So that could be somebody's job to reconstitute dantrolene. So it comes in a 60 ml vial. And the kicker here is that you need a lot of vials of dantrolene, a lot. And at least around here, we wouldn't have all the vials of dantrolene because it happens so infrequently. Our facilities would only carry maybe half of what was truly needed. And then a local hospital that we had an agreement with would carry the other half. So if one needed it or the other, they'd call and go get it very quickly. And the reason for that is it's very expensive. The drug is expensive, and it just happens so infrequently that they don't always carry what they need, which is crazy. But that's how it happens at my facility. If you're in a bigger hospital with a lot of ORs, I'm sure there's enough. But they're going to continue to give dantrolene for actually, I think it's at least 24 to 48 hours because they could relapse, back if in surgery, they go up to the floor, they could actually start relapsing it all over again. So they have to keep giving dantrolene for quite a while. Okay, so they rapidly administer that. They also give sodium bicarbonate to counteract that metabolic acidosis. So that could be a certification question too. What drug counteracts or treats metabolic acidosis? And that is sodium bicarbonate, right? It's a lot of information here in MH, but I can promise you there will be a certification question about it at some point, all right? So memorize these things, all of it. All right, and that's really all I have for Unit 7 and technically 8 because next week we don't have any discussion video because it's just your review discussion posts by Tuesday. So if you have any questions between now and then, reach out to me. Remember to go back and get any of those things in that you don't have submitted already, and we'll get those graded, right? Good luck with everything you've got going next if you're about done and ready to be released into the field here. Good luck to you, and always reach out if you have any questions. Bye.